Good morning, everyone. Thank you, Tony, for that very kind introduction. Thank you, Mary, for the opportunity to be back on the farm. It's always a pleasure to be here and see familiar faces. So I have one public service announcement before I get started. So my boss, Mandy Cohen, the director of the CDC, has made very clear that no one at our agency can show up anywhere in this country without asking, and I know this sounds a little ridiculous in this building, on this campus at this moment, that everyone get vaccinated against the fall respiratory viruses. And I guess to this group I would say, please make sure your friends, your parents, your children get preventive care for these conditions. Having said that, this morning my job is to convince you that, as Tony mentioned, we need some metrics when it comes to climate, to convince you that the best measure of progress on climate change does not come in the form of molecules of CO2 in the atmosphere. It comes in the lives and health of pregnant women, infants, and children. Now, that may be a long stone throw from where we are right now, but I'll see if I can get us closer over the next few minutes. To start that journey, I want to conjure your imaginations. How many of you have seen The Thinker on campus? Okay. So Rodin, lots of sculptures here. Worth seeing if you haven't seen them. It's a very impressive piece of sculpture. It used to be in front of the Meyer Library, which is now in some landfill. But it used to be in front of the library, and it was a nice image. You look at the Thinker, and then you look at the library, and it's sort of a nice sense. But I have to tell you that seeing it on land, standing on your own 2 feet, really pales in comparison to seeing the Thinker while afloat. And how many people here have had the opportunity to ponder the Thinker while in a boat on campus? Aha, very, very few. 25 years ago this February, you had your chance because El Nino-fueled downpours had flooded the peninsula and turned the Galvez and Lawson malls from roadways into riverways. And as I peacefully slept in my dorm, my fellow classmates were rafting across campus. The rains were so severe that the basement of Coverly Auditorium had 4 feet of mud deposited in it. And the Braun Music Library, where I worked, had the greatest dumpster sale ever. There were about a few thousand LPs in the basement in the archive of recorded sound, put in a dumpster next to the library, and boy, some people had fun with that. Little did I realize how much my time here on the farm would matter so much to what I'm doing right now, which, as Tony mentioned, is leading our nation's environmental public health agency. The year before that flood, not very far from here, I had learned about climate change from Stephen Schneider, the professor of environmental biology and global change at Stanford. If any of you are interested in climate change and you don't know Steve's name, it's worth a look. He was on The Tonight Show with Johnny Carson in the 1970s talking about climate change. And he wrote about this as an autobiography, and it's quite worth reading about the experience. But back then, when he was talking about climate change was primarily a problem for the planet, maybe some penguins, definitely not people. And the imprint of climate change on extreme weather, like that flood that led to people pondering the Thinker on water, was murkier, but of course, no longer. So I started, as Tony mentioned, this job in June. And in case you hadn't noticed, we just lived through the hottest summer in what will probably be the hottest year by a long shot ever in history. And as a newbie at CDC, I would say that this first summer was literally a trial by fire. We had the wildfires in Canada that turned the skyline of New York into something akin to an autumnal pumpkin soup. We had fires in Maui that burned Lahaina back to the ground. Phoenix was over 110 degrees for 31 days. And due to unprecedented droughts, the Mississippi River dried up enough so that salt water started going upstream from the Gulf into the river, putting at risk the water supply of New Orleans. And these, of course, are just a few of the highlights or lowlights from our corner of the world. Similar stories could be told from countries around the world. Each of these events that I mentioned now scientifically bear a clear relationship to the growing tide of greenhouse gases in our atmosphere, and a lot of that science comes from researchers right here like Noah Diffenbaugh. In 25 years, we've gone from murky to in-your-face painful about how climate change matters to people. Now, the good news here is that we are seeing more and more actions to address climate change. But the question, as both Mary and Tony alluded to, and my remarks, is how do we know all these actions are making progress? Because, of course, we've heard that given our country's policies, we're looking at a 40% reduction by the end of this decade in emissions below 2005 levels, and surely measuring the numbers matters. Measuring the greenhouse gases in the atmosphere matters. But that is hardly enough. One of the earliest lessons I learned in treating for patients is you can't treat a patient like a bunch of numbers. A patient could have low potassium in their blood, and you could surely fix that by giving them IV potassium, but you could also give them a fatal arrhythmia by giving them IV potassium. So you'd probably want to be sure that before you give them that IV potassium, you know what you're doing. So the same holds true for our actions on climate change. We can and will definitely need to do more of getting CO2 out of the atmosphere. But let's make sure we do everything we can to ensure we don't inflict the consequence of the equivalent of a fatal cardiac arrhythmia when we do so. At a minimum, when it comes to putting a plug on the spigot of carbon, as opposed to using a vacuum cleaner to suck out the tub, we can take advantage of what may be the greatest health opportunity of the century, namely reduced use of fossil fuels. How many people in the world, would you guess, die before their time because they've breathed polluted air from fossil fuels? And this is a quiz, folks, sorry. I know it's, what is it, 8:30 in the morning? There was coffee. I don't know if there's any left, but by a show of hands, let's say on the order of 1 million people, on the order of 10 million people, a couple people, on the order of 50 million people. See, this is what happens when you have a whole lead up to your questions, is people overshoot. So our best estimates are that there are 8 million premature deaths in the world from people breathing fossil fuel-based air pollution alone. That is 1 in 5 deaths, folks, in the world. Most of them in Asia, South Asia in particular. In the United States, estimates range on the order of 100 to 300,000 people. In comparison, there are about 1 million deaths globally from HIV, and that's roughly on par, the 8 million, with the number of deaths in the United States from cancer. So if we can address climate change and move ourselves away from fossil fuels, we will have a health win that is 8 times greater than the eradication of AIDS. Just think about that for a second. Think of how much the global community would celebrate the eradication of HIV from the planet. And think now about the health gains we could get from eradicating fossil fuels. Now, as my former boss, Gina McCarthy, likes to say, air pollution from fossil fuels is not an equal opportunity killer. The need to center health, and especially health equity, in assessing climate risks goes beyond merely avoiding untoward outcomes. We need to be really clear about the right things to measure. Now, I, and I'm sure all of us, are grateful that health equity has become a more frequent subject of conversation and action in recent years. And I want to take a moment to give a particular point on why health equity matters in the context of climate action. And let's start with one way to think about health equity, which is the opportunity to reach and I'm a pediatrician, a child's full health potential. So, festering health inequalities. When one person has the greater opportunity to lead to their full health potential over another for no choice of their own, are more than a moral wrong. Allowing some people to have their lives harmed and other people's benefit from the harms inflicted, which is the classic problem of environmental health justice, transgresses every cultural's moral foundations. But it does more. Allowing health disparities to fester creates the fertile ground for, as an example, pandemics to thrive. Take a good moment to think about what we just watched with COVID between 2020 and 2022. Who was most affected? Who will be burdened longest? And you can hopefully see, as I plainly do, that health inequities are bad for everybody. The fissures in society that health disparities create are the very channels that societal shocks, including climate shocks, the extreme heat, floods, droughts, heat, more intense hurricanes, course through. Who is most sensitive to this reality? Well, since you're at a symposium about maternal and child health, you guessed it, pregnant women, infants, and children. Let me take a moment to explain why. Leading causes of maternal mortality include malnutrition and pregnancy-induced hypertension. Anemia, a major contributor to maternal mortality globally, depends on access to dietary iron. For most women in the world, that iron comes not from animals, but from plants. And while we tend to think of climate change, health, and the connection of extreme events to those things, we ignore the reality that carbon dioxide itself directly affects our health. In this case, through what carbon dioxide concentrations in the air due to the nutrition of foods that people eat. So if we increase, as we have, the concentrations of carbon dioxide in the atmosphere, the plants that sustain us have less nutrition, including less iron. Research of Sam Myers and others have found that the harms of iron deficiency, anemia, and pregnancy are profound, with the expected rise in current and growing rise in atmospheric concentrations of CO2, and those health burdens of anemia on the pregnancies and those children is outsized in, of course, the countries where those burdens are already greatest. Of course, having anemia in childhood ain't good either. Recent research has found that not only do we see children perform less well in school, have more behavioral problems when they're anemic, it actually physically reshapes their brains. Now, the other outcome with pregnancy I mentioned that is in the climate change sphere, among many, is pregnancy-induced hypertension. So last night, I got to see Steve Luben, whom I'm not sure is here this morning, but Steve has dedicated his career to working in Bangladesh, where we already see this problem. Salt water, there's this great experiment that many of us probably did at some point in our education where you have a beaker and you put a semi-permeable membrane in it to understand the concept of osmosis. And you put some food dye on one side and you watch the food dye go across the semi-permeable membrane but not the saran wrap without the holes in it. Well, that's what's happening to our coastal water, folks, is salt water in the oceans is going into the fresh water underground that we drink. And this has already happened in Bangladesh. Now, there are many factors that contribute. You've got subsidence in land, so you pump out all the water from the ground, the land sinks. You put buildings on top of the land sinks. And while we're doing that, sea levels are rising. So by mass force, and I'm mindful that I learned about these kind of things about half a block from here in the chemistry, we all had to take organic chemistry. We're pushing salt into our drinking water, and women showing up to prenatal clinics in the southern parts of Bangladesh have much higher rates of hypertension because they're drinking more salt in the dry season as the saltwater concentration of those aquifers grows. Now, you might think that this is a problem limited to places like Bangladesh or maybe Pakistan, but remember what I said at the outset, folks. One of the calls I got this summer was about what do we do if the salt water in the Mississippi reaches New Orleans? Because that salt water is like delivering half normal or higher concentration saline to babies, to women who are pregnant. So fortunately, that risk is abated, but let's be clear, it's not going away. So when I say we can measure the progress on climate change in the lives of women and children, these are but a few examples. But again, I mentioned I'm a pediatrician, so let me talk about children for a second. So I've worked with pediatric residents, medical students for a good long while now. And one of the questions I love asking them is about asthma management, because we're always getting hammered about asthma management because it's pretty common. We've got very good guidance on asthma management in this country, very evidence-based, especially for pediatrics, guidance on how to manage asthma, which involves step therapy, meaning you start a kid with asthma on a bronchodilator. If that doesn't do it, you put them pretty quickly on an inhaled steroid. If that doesn't do it, you sometimes use a combo of a long-acting beta agonist, bronchodilator, and a steroid. And the residents and the medical students, they know this backwards, forwards, inside, and out. But the question I often ask them is, you're seeing a kid in the emergency department for the 4th time in 2 months with an asthma exacerbation. And what are you going to do about it? And they said, well, I want to up their inhalers. And I said, well, they're kind of on all the inhalers we can find. I mean, we can throw some Montelukast at it, but everybody knows that doesn't do anything. And is there anyone who sells a Montelukast here? Sorry. Well, does anyone smoke in the house? They often say, is somebody smoking in the house? I said, no, nobody's smoking in the house. Did they get a new dog? No. Did they get a new cat? No. And eventually they're like, well, I don't know, what are we going to do for this kid? I said, well, where do they live? They live next to the freeway? Do the parents idle the car in the attached garage? That's a good one. Do they have a wood-burning stove? Turns out that in too many cases, this also goes for coronary infections, there's some source of air pollution that's causing this. The best estimates from Susan Annenberg's work at GW are that 1 in 5 children in the United States have asthma, i.e. would not have asthma. 1 in 5 children get asthma because they're breathing tailpipe emissions. That's the national average. But if you look in places like Oakland, you look near the freeways of Oakland in a predominantly black American community, that's about 3 in 5 children. So climate action, air pollution, is a big deal for child health, but it actually isn't the biggest deal. The biggest deal for children, in my mind, when it comes to children in this country and around the world, and there are lots of ties, and I'm not going to get into them all, is the reality that climate shocks are adverse child events, or ACEs. ACEs can promote long-term health problems. These examples of ACEs are physical and emotional abuse and neglect, witnessing violence, especially in the home or community. Importantly, losing a home to a child. Anyone here asked a child to draw their family lately? So there's an interesting thing. For children who have stable homes, they draw their family and they're very prone to drawing their home. It's part of a child's identity. They might draw a place that is a part of who they are. Losing a home to a flood, a fire, becoming impoverished from a disaster also count. A recent global meta-analysis published in The Lancet found that with 4 ACEs, the odds of developing cardiovascular disease in an adult and cancer double as an adult. Teenage pregnancy, depression, and substance abuse disorders more than quadrupled. Committing violent acts increased by 8-fold, and suicide by a staggering 30-fold. What the disaster headlines that you all saw, that we all saw, from this summer don't show us is the long tail of ACEs due to climate extremes. They also don't show us the intergenerational inequity of climate change. At a time in this country when so much division appears to separate us from each other, we must work harder than ever to find the common ground to stand on, to make paths to move forward on. In all my time as a pediatrician, and certainly in my time at CDC, I have yet to meet the grown-up in the room who believes that every child, who believes anything other than every child, deserves to grow up in a world as good or better than the one they got. This makes climate action an irreplaceable part of honoring the value of intergenerational equity. Given the warming trajectory we're on now, a child born today in the United States can expect to endure 3 times more heat waves, twice as many droughts, and 1.5 times as many wildfires in their lifetime as a child born in this country in 1965. Taking the longer view helps clarify why climate progress can best be measured in the lives and health of children, infants, and women who are pregnant. And my hope is that as we all think about how to bring the solution space forward on climate change, how we take the actions we must take to address this opportunity to improve the health and welfare of the planet, that your voices, the voices of people in the health community, are absolutely first and foremost at the center of how we make our choices. Thanks for having me. Great to be here.
Wow, thanks so much, Ari. That was just, got all choked up about that one. So we'll do is have a question answer period. I'm sure you have a lot of questions about what Ari had said, but I'd like to invite our second speaker up, Tom Luben. So Tom actually is a senior epidemiologist of the Center for Public Health and Environmental Assessment at the EPA. We talked last night about how it's an environmental protection agency, but they're what are they protecting? And Tom is one of the leaders in understanding how the environment influences health. And so here to talk about some of the work he's done and also his comments as well. So Tom, thanks so much for joining us.
Good morning, everyone. I'm so happy to be here this morning, and I just want to say a quick thank you to Mary and Tony and Grant and Netta for all the work they did to allow me to be here. And I'm really happy to be talking to you today about specifically climate change and maternal and child health. I have been working as an environmental epidemiologist at EPA for 16 years, focusing on maternal and child health outcomes, mostly looking at air pollution, some water pollution, and now more recently, climate change, things like extreme heat, extreme cold, extreme precipitation, and natural disasters. And so I'm going to walk through today some of the work that we've been doing at EPA related to this topic. And you'll notice the title here, Tackling the Climate Crisis, and that comes from EPA's priorities and missions, and we'll get into that. But I also want to acknowledge here, I'm going to try to talk about 4 different things today, all in 25 minutes. I know that's ambitious. I'm going to have to go a little bit quickly, but I'm hoping that this will kind of pique some interest. You'll have some questions. I'll be around all day today. I'm hoping that you'll be able to ask questions. I know that we'll be available at lunch today as well, so please come up. I'm much more comfortable talking one-on-one, so I would love to have those conversations with each of you as we go through. So I'm going to start at the highest level, and that's EPA's kind of administration and their priorities related to climate change. And as you may be able to imagine, this changed drastically with the current administration back in January of 2021. There was an executive order very early in the current administration that directed us to tackle the climate crisis both at home and abroad. So, no big task, something we could clearly do in 4 years. But it's clearly a priority of this administration and something that we're working very hard on at EPA. And so at EPA, we have a strategic plan for the next 4 years. Goal 1 is tackling the climate crisis. And then goal 2 I put on here because I don't think these things can really be separated or disentangled from one another, is taking decisive action to advance environmental justice and civil rights. I think these go hand in hand, and I don't really think we can have one without the other. And so how are we doing this? EPA program and regional offices are coming up with implementation plans for climate adaptation. We continue to work under the Clean Air Act to regulate greenhouse gases and the criteria air pollutants. And then we have received money through the Inflation Reduction Act and the Infrastructure Act so that we can distribute grants related specifically to climate change, and some of those will focus on maternal and child health. I don't need to spend a lot of time on this slide with this audience, and I already mentioned climate change is a public health and an environmental justice crisis. We can't disentangle one from the other. And everyone in the country is vulnerable to worsening health and welfare due to climate change. And as Ari already mentioned, it's not equal opportunity. Some are more at risk than others. And pregnant people, children, infants are part of that vulnerable community. And so looking at the impacts of climate change on these different populations, the underlying health, demographic, and socioeconomic factors is going to be really important. And EPA is hoping to address this through multiple pathways, including clean air and water, healthy ecosystems, and then resilient communities, because this EJ is a big part of this, right? We can't disentangle the social determinants from the built environment from the environmental contaminants. They all go together hand in hand. And so I want to talk about ORD is the Office of Research and Development, which is where I sit at EPA. They've tasked us with this three-pronged approach. And I'll say right now, it's very ambitious. I don't think we're there yet, but I think it's important. And so we want to talk about interventions. So how can we protect public health? Are there recommendations we can make at the individual level, at the community level, for people to be able to protect themselves? How can we prevent the climate crisis from worsening? This may include informing preparedness and adaptation, as well as some long-term resilience programs. And then finally, we need transformation. We need the underlying systems and structures to change if we are really going to address the climate crisis. And so these are the three prongs that the Office of Research and Development has identified and what we are ambitiously trying to work on as we do research and conduct work related to climate change. So like I said, this is going to be kind of the highlights of each of these points really quickly. We're going to move on already. And I want to talk about a report that EPA issued earlier this year on climate change and children's health and well-being. And we'll talk a little bit more about this, but I think this report is very timely and really important. And it involves both climate change impacts and a risk analysis. And the objective was to quantify and monetize climate impacts across sectors in the US, including how risks can be reduced through greenhouse gas mitigation and adaptation. And so there's a number of different scenarios that I'll talk through in brief detail, but it used a common modeling framework using kind of the same inputs and assumptions for each of the different scenarios. And we used different impact models that were supported by scientific literature. And this builds upon some of the previous reports from this group. So what was the motivation for this report? We know that children face higher health risks from the impacts of climate change. Ari demonstrated that very eloquently already this morning. And so we picked several different climate stressors and several different children's health impacts that I'll go through in a little bit more detail. And we did this at a national scale, multi-sector level that supported this report and focused on quantification of climate risks, forecasting into the future. So what can we expect with 2 degrees Celsius warming, 4 degrees Celsius warming? And this supports the administrator's priorities on both the climate, on children's health, as well as on environmental justice. So this is a sneak peek of the overview of what's in the report. And you can see the different scenarios that I mentioned. There are 5 here. So we look at extreme heat, air quality, changing seasons, flooding, and infectious disease. And then for each of those 5, we do a detailed analysis on one specific health outcome. But then we also acknowledge where there are emerging climate impacts, where the evidence may not be quite certain or strong enough for us to do quantification, but we want to acknowledge those things. And so I'll talk a little bit about learning loss, about air pollution and asthma, especially among children. I'm not going to focus a ton on the aeroallergens today just for time, but I will touch quickly on the coastal flooding and on Lyme disease. And then for some of these emerging impacts, I would encourage you all to go to the report, and there is a link and a QR code in one of my subsequent slides. And I assume the slides will be shared with everyone? Yeah. So very quickly going through the methods that were used in this report, and as I mentioned, these methods are common for each of those different scenarios. So step 1 is to establish current vulnerabilities among children. And so to do this, we're relying on the current peer-reviewed literature that has linked and quantified the associations between these different climate scenarios and the different health outcomes. And then using those effect estimates or I'll call them effect estimates, it's just easier. We are going to project future environmental conditions using environmental forecasting, climate forecasting, meteorology, and then come up with kind of what we expect under future scenarios. And I mentioned already that we did this for both a 2 degrees Celsius and a 4 degrees Celsius increase in global average temperature. And then just to kind of sum up on this report, we did identify some key research gaps. So this report is limited just to the impacts in the contiguous United States. It does not include Alaska, Hawaii, Puerto Rico, or other US territories. And it's not a global report. It's really just focused here in the US. There is a lot of interest in how climate change may be affecting mental or developmental health among children, and we were not able to include that. The research is growing quickly, but we did not have research available at the time of this report to include that. There's always the potential to improve forecasting for what climate scenarios might be in 2030 or 2050 under these different climate change scenarios. And then we would hope to expand the studies to focus on compound effects or cumulative impacts at a national scale and under different demographic characteristics. But here is the QR code if you want to download the report. And we have online available the full report, some summaries, and then if you really want to dig down into the data, those are available online as well. And then for more information, some of my colleagues at EPA who worked really hard on this report, you can reach out to them as well. Okay, so halfway through. I do want to talk just really briefly. So EPA is a regulatory agency. It is a public health agency. We also give out grants and we do research, right? So we've talked a little bit about EPA as a regulatory agency, the public health nature of it. I just wanted to go over some of the grants that EPA is funding now and some future potential for funding opportunities through EPA that may be of interest to folks here. So these are some examples of funded research that have recently gone out for projects related to climate change and maternal and child health. So you can see here, there are projects related to pediatric susceptibility and temperature, early life vulnerability of climate-driven wildfire events, and there are a couple different wildfire projects here. Schoolyard spaces, which I think will be important, and we'll talk about that in a minute. More wildfire impacts on school children, and then indoor PM 2.5 associated with health impacts in children. So that's just a very quick list of some of the grants that have gone out. We also have a RFA for early life stage vulnerability to environmental stressors and cumulative health impacts, specifically related to children in underserved rural communities, which will address, some of these projects will address climate change and children's health. So that RFA is already closed. They're reviewing the grants, and hopefully the awardees will be announced later this year. But coming up, we have money from the Inflation Reduction Act, specifically kind of pigeonholed for environmental and climate justice program, and so there should be some awards coming up. All of that money needs to be distributed by 2026. So there should be some recent opportunities for grant funding related to climate change and maternal and child health. And then I just threw up here the general link if you're interested in grant opportunities from EPA. Okay, so I've gone through all of this very quickly, and I'm going to try now to spend a little bit more time digging into some of the results from that children's health report, and then some other individual results from some epidemiologic work that I've been a part of. And so now that we're talking about the research, we kind of have two different things. We're talking about the work in the report, which is nationwide, what we call an ecologic analysis, right? So we're not looking at individual level data, but we're looking at outcomes at the county level across the United States, and then we're linking that and looking at associations with some of these different climate change scenarios. And then later at the very end, with the little bit of time I have, I'll talk about some of the individual level observational epidemiologic analyses that I've been a part of. Okay, and so one of the reasons I want to spend time on this is we had a conversation at dinner last night, and Mary mentioned that one of the things that would be important is having kind of quick anecdotes or statistics that she can use to provide to administrators or others, right, to kind of highlight the importance of climate change on maternal and child health. And I think that some of the graphics from this report could really serve that niche for you very well. And so the first scenario that I wanted to talk about is heat and learning. So here, and I mentioned before that we use kind of the same method, same structure, so you'll see this kind of step 1, step 2, step 3 framework on each of these slides. We looked at learning on standardized tests in counties across the United States. And then we also looked at the average daily maximum temperature during the school year. And we identified the counties that were most at risk for learning loss due to extreme heat events. And so you can see here that we highlighted the states that had the largest losses, Wyoming out in the Intermountain West, Michigan in the upper Midwest, and then 3 states in New England, Vermont, Maine, and New Hampshire. And I think that part of this is, here you can look at the kind of monetized results under the 2 different scenarios, 2 degrees Celsius and 4 degrees Celsius. But if you look on the right-hand side of the screen, you'll see that the cost of installing HVAC in school systems would be less than the cost attributed to these learning losses, but that there was the study that showed that ACs in schools is not enough to totally eliminate the learning loss, that these states need AC both in school and at home if they are to really prevent the learning losses attributable to extreme heat in these different areas. The next one is looking at air quality. So we're specifically looking at changes in ozone and particulate matter, 2 of the most well-known criteria air pollutants. And we're looking at changes, climate-driven changes in the concentrations of these 2 ambient pollutants, as well as wildfire activity and dust in the Southwest. And so we looked at the concentrations of these pollutants at the counties across the country. And then we looked at rates of asthma diagnoses among children attributable to these climate-driven changes. And here we see the 5 states with the biggest impacts, Washington State up in the Pacific Northwest, Ohio in the Midwest and Kentucky, and then on the East Coast, Maryland and Washington, D.C. And so here you can see that with 2 degrees Celsius or 4 degrees Celsius warming, we can see the rise in new asthma cases, incidence of hay fever, rhinitis, ED visits for asthma, hospital admissions, infant deaths, and school days lost. And then each of these can be monetized as well if you wanted to get a kind of a dollar value of what this will cost should these forecasts come to fruition. The next one I want to talk about is coastal flooding. I already talked about the importance of the ACEs and how losing a home to flooding or some other natural disaster can be really important in maternal and child health. And so here we are looking at coastal flooding from storm surge. And here I talked to some of my colleagues in the climate division, and they said, please point out that 50 centimeters, 100 centimeters, this is huge sea level rise. So we're not talking about minuscule amounts. So this is under a scenario where sea level rise is quite large. But we would expect to see, potentially 1 million homes where children live affected by sea level rise. So were we to observe this forecasted level of 50 centimeters or 100 centimeters. And so just contributing more to these ACEs that can lead to further lifelong health disparities. And here you can see the areas where the coastal flooding would have the greatest impact. A little bit along the Pacific coast, but mostly we're talking about the Southeast and the Gulf, Louisiana, Florida, Georgia, South Carolina, and North Carolina. And then finally, I'll talk a little bit about infectious diseases. Here we're looking at climate-driven changes in Lyme disease. And so we're looking at how much Lyme disease may happen because we have longer seasons, warmer days, warmer nights. And so here you can see the distribution of new Lyme disease with a 2 degrees centigrade increase in temperature. And again, we have the upper Midwest, Minnesota, Michigan, and then the Northeast, Vermont, New Hampshire, and Maine, where we see the largest impacts there. I'm sorry, I went the wrong way. Okay. And here you can see the numbers of new cases. And for Lyme disease, with a 2 degrees Celsius increase, we're seeing about 2,600. But were we to see a 4 degrees centigrade increase in temperature, it's an order of magnitude larger, 23,000 additional cases of Lyme disease anticipated under that future scenario. Oh, sorry. Okay. So in my last 5 minutes, I'm going to just spend a little bit of time talking about some of the observational studies that I've been involved with, focusing on climate change and maternal and children's health. And I'm going to talk about birth defects, an area that I've been involved in a lot. And so how could climate change be related etiologically to birth defects? Well, we know that elevated body core temperatures can have a teratogenic effect, but there's really been little research on weather-related extreme heat events and birth defects. And we're pretty sure that pregnant people are vulnerable to weather-related temperature and extremes. So I'm specifically going to talk about a series of studies that I was a collaborator on from the National Birth Defects Prevention Study. Gary Shaw is here. I think he's a collaborator on each of these projects as well. So if you have additional questions and you can't find me, you can always seek out Gary. But for those who may not be familiar, the National Birth Defect Prevention Study is a multi-center case control study that focuses on 30 major birth defects and live unborn controls, live-born unaffected controls, and it's a pretty long study, so this was going on from 1997 through 2011. One of the strengths of the study is that we have a clinical geneticist that reviews each of the records to kind of confirm the birth defect diagnosis. We look at chromosomal abnormalities, single gene conditions, and then major syndromes, and those are excluded from the study. And then the women, the mothers complete a computer-assisted telephone interview anytime from 6 weeks after delivery to 24 months after delivery. And so this is a huge strength of the study. Many times when I'm reviewing epidemiologic research of birth defects, we are seeing research that depends on records from birth certificates. And so this hour-long computer-assisted telephone interview gives us so much more information on occupational exposures, on medications that the mother might have been taking during pregnancy, on their dietary habits, on a whole host of other potential covariates that we typically wouldn't have data on. And then additionally, we have an address history starting from 3 months before conception through pregnancy, so we can link the geocoded residential address for each person, and we know if that changes during critical windows of embryogenesis. And so I don't have a ton of time, so I'm going to go through this very quickly. Again, please find me afterwards if you have questions about any of these specific studies. I do have additional slides if there are questions. But we had a series of 4 studies. And so the first study, we looked at extreme heat events during the relevant developmental window of embryogenesis and neural tube defects. And here, we did not see any associations between extreme heat events and neural tube development, or neural tube defects. So great. But then we moved on and said, okay, we looked at neural tube defects. What if we looked at congenital heart defects? There are many more of them, many more different phenotypes of them. And so when we looked at the congenital heart defects, we found that generally there were null results or no associations observed for many of the different phenotypes. But when we looked at a long duration of extreme heat in certain parts of the country, we did start to see associations with 2 specific congenital heart defect phenotypes, ventral septal defects and atrial septal defects. And this was mainly in the south and the northeast parts of the US. And so we went just a little bit further and we said, okay, we've done some work before to show associations between air pollution and these same congenital heart defects. Could air pollution and extreme heat be working jointly together, or could one modify the other? And so among the same population, we looked at women who had low exposure to PM 2.5 air pollution exposure and no exposure to an extreme heat event. And compared to those women, the odds of a ventral septal defect in offspring associated with high PM was elevated only among women who also experienced an extreme heat event. So there seemed to be something about the combination of extreme heat and high ambient air pollution that may have been driving some of these associations that we were observing. And then finally, we just went one step further, and instead of saying any extreme heat event, we looked at both the duration of the extreme heat event. So is it important if it's 1 day, 2 days, 3 days in a row where someone's experiencing extreme heat? We did find that there is some evidence that the duration of the extreme heat event, as well as the magnitude of the PM 2.5 exposure, so how high is the ambient concentration of that exposure, had an impact on congenital heart defects, and specifically the septal defects that we had seen in the other studies. And just a little bit of work in progress that we're doing at EPA right now. Working with some trainees, we are looking at gestational and postnatal exposure to wildfire smoke and prolonged use of respiratory medications in early life. We're still interested in extreme temperature, but we're looking at diurnal temperature differences. So is the night low and the afternoon high, is the difference in those two measures important? There's been some discussions recently about even if the daily high is not relatively really high, if it's not cooling off at night and sleep could be impacted, that could be a mechanism by which climate change and extreme heat could have an effect. We're looking at extreme heat exposure and air pollution with preterm birth. I had just talked about birth effects, but we're also looking at preterm birth. And then looking at whether or not residents in a historically redlined neighborhood could modify the association between extreme heat and some of these birth outcomes. Again, tying in together the built environment, the social components, social determinants of health, and climate change. And so I did it. I'm only 1 second over, my time, made it through everything. Just a few additional resources. EPA played a large role in this climate change and human health assessment report, which was looking at health across the life course. Children were identified as a population of concern. And then I threw up the website here for EPA's Office of Children's Health Protection, which is another great resource. And that is it for me. Thank you all very much.
Thanks so much, Tom. And a lot of food for thought for the question and answer period right after this. So lastly, before the Q&A, we just wanted to bring up our last speaker of this session, Eran Ben-David, who's Associate Professor of Medicine here at Stanford, to provide the Stanford view. Along with Steve Luby, Eran is really pioneering this effects of climate change on human populations. And so we'd love to have him come up and talk about. There's a lot we don't know about the environment's impact on the lives of mothers and children, especially living in poverty. So please, thanks so much for doing this. All right, you're all set.
Hi. Thank you, Ari, Tom, Tony, Mary. Thank you, the MCHRI staff, for inviting me. My name is Eran Ben-David. How do I click? Okay, and I'm going to provide the view from communities living in the world, among the world's poor. I'm going to try to make 3 points today. The first is that economic development, protecting the environment, and child population health of those living in low and low-middle income countries, I'm going to call them LMICs during this talk, are in tension. And that except for one factor, and given the previous speakers, that factor is not going to be a surprise to most people, there's a lot of uncertainty about how environmental drivers affect population health in poorer countries. And that environment health trade-offs are complex and different. In fact, that environmentally protective trade-offs that may seem intuitive here are not intuitive in LMICs. Okay, this is the outline. I'll go through an overview of maternal and child population health. I'll talk about theories of global health improvements, and the challenges ahead, the tensions that I mentioned, and some of the evidence about what is known and less well known about environmental drivers of population health, and then try to talk about the trade-offs and issue a challenge to us here. A word about how I got here. My clinical training is in infectious diseases, and that was my path to global health work. My work on foreign aid for infectious disease control explored how actions here in high-income countries impact the health of low-income countries. Got me to think a lot about the relationships between upstream drivers of health interact with the population health changes, things like education and armed conflict. And on to morphed into climate health work over the past decade or so, much of it in collaboration with Marshall Burke and Sam Hafniel here at Stanford. I owe them much of this credit to much of my success in this area. This map here is from one of our early studies that shows the subnational regions in sub-Saharan Africa that are not on track to achieve the Sustainable Development Goals by 2030 at the rate of historical mortality decline. Keep an eye on West Africa, it'll come back. Okay, let's tackle the first three parts of this outline. If the New York Times were to publish just one issue every 50 years, I hope that this headline would be above the fold. Compared to 1950, 15 million fewer children under 5 die every single year. Since 2019, only about 5 million children die a year. There's a similar proportional reduction for pregnancy-related deaths. I'm going to focus on children for the majority of this talk. This decline is particularly remarkable in the context of the global population change. And so there are actually twice as many children today than in 1950 and 3 times as many young women of childbearing age. For better or worse, this decline could not have happened without the world getting wealthier. Rich countries have better child survival, and as countries get wealthier, their children get healthier. This is one of the most well-established relationships in global health. This here is what is known as the Preston curve, named after Sam Preston, that established that relationship initially. And it's true for just about every kind of health outcome. This one is showing infant mortality or child mortality on the y-axis and national wealth on the x-axis. As countries get wealthier, their infant mortality declines, first rapidly, then slowly, but continuously. Now, to be fair, not all health improvements have been the result of wealth accumulation. In fact, one of the unique aspects of the Preston curve is that as over time, for the same level of wealth, we see health gains. And so if you look at the curves for 1980 and 2012, let's say at around $20,000 per capita, for countries that have been at $20,000 per capita in 1980, later on, 30 years later, their health has improved, even for countries at the same wealth level. This is often the result of interventions that are not related to wealth, things like accumulation of knowledge, public improvements, vaccines that are very ineffective, very low cost, malaria bed nets, things like that. But the relationship between wealth accumulation and health improvements is hard to escape. Let's dig into the drivers of child mortality in low and middle income countries. The bars are the 4 largest risk factors, and the colors are the actual causes of child under 5 deaths. And this is true both for low income and middle income countries. And so malnutrition, this is in 1990 and this is in 2019, okay? The malnutrition, water and sanitation, air pollution, tobacco, The top three have remained top three. The specific causes have also more or less remained. Things like low respiratory infections, diarrheal diseases, measles, worth noting, has nearly gone away as a dominant cause of child mortality. But really the main story here is that malnutrition is the dominant cause of under 5 or risk factor for under 5 mortality in LMICs. And this is the Janus face of malnutrition. It is the #1 risk factor for child deaths, was and is. And it is also the #1 savior of child deaths. Based on this, if I wanted to focus on improving child survival across the world, I would focus on malnutrition, both because it is the #1 challenge and because, I mean, look at this trajectory. There's a lot of, this is very promising. And this is where we're going to try to bring in the relationship between economic development and child health improvements where we're also going to bring the climate impacts too, and where they start interacting. High yield crops, really the link between economic development and global child health could not have happened without the development of ammonia fertilizers. Ammonia fertilizer production is very needed for the crop yields that have helped many escape malnutrition. But it is a very CO2 intensive process, consuming about 2% of the global energy use, mostly natural gas and coal. For the Haber-Bosch process. Switching either the energy sources for fertilizer production or the process is possible, but not easy, and can come at the cost of malnutrition. Large-scale farming brings into view the importance of things like heavy machinery that use diesel and internal combustion engines. The process of electrifying the equipment for farming and for large-scale farming is very far behind that for personal vehicles. And you can imagine also that in low-income countries, nobody has seen any Teslas in Lagos, as far as I can tell. And so doing that for agricultural machinery is even further behind. In addition, the production of steel consumes about 8% of global energy use. And the same for CO2 emissions. Again, something that is both fundamental for economic development and also a large tax on the environment. For better or worse, production of poultry and pigs has contributed to lower rates of protein-calorie malnutrition with very high environmental costs. The majority of deaths from protein-calorie malnutrition today are in Africa, where there are still not enough chicken or livestock. CAFOs are the equivalent of commercial farming for animal feeds. The concentrated animal feeding operations, again, has been something that has both useful for child malnutrition, but also very high environmental costs. Plastics, so ubiquitous, so necessary. In most of sub-Saharan Africa does not have water filtration and chlorination and piping systems. What we take for granted, and really at this point we think hard about replacing the amount of plastics and the types of plastics we use in our public systems. For much of sub-Saharan Africa, it is, pardon the pun, a pipe dream. They cannot do without the kinds of plastics that are necessary for producing sustainable and clean and safe water systems. And cement. We have people here in our school that are working on replacing mud floors with cement floors. Reducing the exposure to soil-based helminths and improving the sanitation conditions in the home. But the production of cement, again, very, very energy costly. About 10% of all industrial energy goes to cement, very coal and petroleum intensive industry. About 45% of all global CO2 emissions come from concrete production. Steel, fertilizer, cement, plastics. As much as that makes me uncomfortable, these are arguably in the pantheon of child health interventions. And so that brings me to the first point that I was trying to make, that economic development, protecting the environment, and child population health in LMICs are in tension. And perhaps the most underappreciated part of that tension is that prioritizing economic development with too rapid environmental protection, switching to renewable energy, reducing environmental impact of food production systems too fast is potentially a brake on health improvements, especially in Africa and South Asia, the world's hotspots of child vulnerability. Okay. But isn't climate change an existential long-term health risk for children in LMICs? In other words, will we not lose any gains in child health if we do not deal with climate change now? This is the kind of a common and reasonable concern. For example, temperatures are increasing globally. Extreme heat is dangerous to health. Children in poor countries live in general in conditions of greater vulnerability, more intense disease ecology, less extensive and organized public health systems. Therefore, it seems sensible that warming temperatures would pose a unique risk to children living in poor countries with a growing expected risk as temperatures continue to rise. From the population health perspective, the evidence for this is not very strong. I'll go through a few of the older or more extensive studies that look at population health and large-scale evidence for relationship between temperature and mortality. This is perhaps one of the foundational articles in this whole field from the early 2000s. That examined evidence from high-income countries. They looked at heat waves. They looked at cardiovascular and respiratory disease. I'm not going to go through a lot of the evidence, but their conclusions are that to date, a number of studies have shown that mortality is increased during heat waves and that ambient heat exposure, primarily indexed by temperature, is positively associated with mortality. And that the findings suggest that persons with pre-existing cardiovascular and respiratory diseases have increased risk of death associated with ambient heat exposure, and that risk is higher for several populations, including the elderly, infants, persons of low socioeconomic status, and that's kind of the primary findings. So the evidence from high-income countries really focuses on pre-existing cardiovascular, respiratory diseases. Maybe there's a moderate signal for children. Here's a study that was published last year looking at not just high-income countries. So this is, they're going to use 40 countries' subnational data and estimate age-specific mortality temperature relationships by a team of very successful social scientists that care about these issues. This is the sample of countries. There are 33 EU countries and then 7 other countries. Unfortunately, India did not have the age breakdown and was not included in the primary analysis. But Brazil, Chile, China, and Mexico are notable middle-income countries here. Okay, here's their main figure and some things to notice. One is that the age of interest of their primary effects is over 64. The data, the information in these small circles really gives you a sense of the global population that is present in each of these combinations of national income, low, middle, or high, and ambient kind of temperature climate, cold, temperate, or hot. And you can see that the majority is certainly moving towards the hot range of the world. And you can see that the effect seems to become more moderate as income rises. Okay, so higher income countries seem to have a little bit of a less extreme effect compared to low income countries. And moving from cold to temperate to hot regions seems to reduce the effect also of heat across all income groups, perhaps because of adaptation or some kind of baseline conditions. So this was the effect for older adults, and the effect for children, for better or worse, is flatter and less compelling. And again, seems to have a little bit more of a inconsistent relationship. Hard to know what is, if there's a very strong take home from this. Finally, the last study I will go through for temperature is this study that was done called Heat, Humidity, and Infant Mortality in the Developing World. And they looked at, you can see in this map, about 30 or 40 mostly low and middle income countries, and examined again at scale relationship between temperature and infant mortality. They examined both air temperature, dry temperature, as well as what they call wet bulb, which is a combination of air temperature and humidity. And this is their main figure. Again, there's a rising rate of infant mortality at the low end of temperature, and maybe a little bit of an increase at the high end. Although again, it's noisy enough and not very strong, both for dry bulb as well as for wet bulb. And as a point of meta research about this study, this is the most compelling large-scale study for low-income countries that looks directly at the mortality impacts. This study remains as a preprint or as a preprint server paper since 2018, and one wonders not only about this study but others that have not been published on this topic. So there's no question that extreme temperatures are potentially hazardous, that the hazards of extreme temperatures seem more consistent and serious for older adults, and then the evidence from commonly hotter but less prone to global warming low and middle income countries is sparse and less conclusive. That does not mean that environmental factors are not major drivers of child health in LMICs. In fact, if you remember this figure of the risk factors for child mortality, air pollution is right up there in 2019, and in fact is an important driver of child and infant mortality. This is work that I've done again with Marshall and Sam and our colleague Jen Burney, and it is one of the more compelling and consistent findings that I've ever been a part of. Whether you look at the relationship at the cross-section over time within the same village, whichever way, higher particulate matter concentration is associated with higher infant mortality rate. And this is across the entire range of particulate matter, all the way from 0 to the very high ends of particulate matter exposure. In fact, the relationship is so strong, and again, sort of West Africa comes up red here, that in some parts of the world's poor, 30 to 40% of infant deaths can be directly attributed to particulate matter and poor air quality. This again is a very consistent finding again and again. We see it when we look at other causal approaches of identifying the impact of particulate matter using dust pollution from some of the big dust bowls in sub-Saharan Africa. Has been examined again by Marshall and their group using global biomass fires, looking at the impact on infant mortality when the biomass, when a big brush fire, stubble fire is upwind from the child's home. This is again very important for India, where stubble fires have caused some of the world's worst air conditions, kind of hard to imagine. And for many people who work here directly, including Steve Luben, on air quality in Bangladesh. Which brings me to the second point, that except for air pollution, there's a lot of uncertainty about how environmental drivers affect maternal and child population health in poorer countries. It does not mean that there's no or never will be impact, but the evidence is just not as strong for other factors as it is for poor air quality. Okay. Let me try to bring and make an argument about the trade-offs that will help us protect health and protect the environment in low and middle-income countries. And I'll build the argument based on the gaps between low-income and high-income countries. The sense of global injustice and the urgency to prioritize health and development is fueled by the fact that despite progress, still about half of all under 5 deaths are in African countries, about 80% if you count South Asia in that. These maps that show you kind of the distribution of under 5 deaths across the world always light up sub-Saharan Africa. Just looks different from the rest of the world. India, Pakistan, Afghanistan are just behind. And that there's a yawning gap in economic development that is hard to reconcile and feel good about. Again, prioritizing improvements in food security and nutrition are a #1 public health and global health priority, with water and air quality as other high priorities. That makes sense. The kind of relationships between child deaths that are attributable to malnutrition between places like the US with 330 million people and Pakistan and Nigeria that have in the 200s is an order of magnitude. And if you look at the kind of relationship between the amount of calories per day that hundreds of millions of children here in the poorer parts of the world, one can make an argument that maybe in the United States this is too high than the number of calories per day in relationship to our national income. But breaks your heart to think about millions, hundreds of millions of children not having enough to eat, going with chronic hunger, chronic food insecurity. The surest path to improve nutrition, clean water is, for better or worse, as much as that's a tough bargain, is economic development. Improving air quality is clear path towards forward with environmental protections, and that is another compelling but separate issue. And then, so the gap in health outcomes, and then the gap in economic development, that's a challenge to shared priorities. If you look here again at the Preston curve, you can see that the wealthy countries, the wealthy club of countries, has stretched out, has become much wealthier than the poor sets of countries. The world's wealthiest 10 countries, their GDP has increased on average by 30% between 1980 and 2020. For the poorest 10 countries, it has remained more or less the same. Really no change at all whatsoever. And in fact, urging the world's poor to use anything short of the most high-yielding fertilizer or maximally efficient farming practices really may slow gains in child health. And this challenge of reducing malnutrition for Africa's current residents is compounded by its expected population growth to about 4 billion from 1.5 billion by 2100. It'll become about 40% of the world's population. The only major region of the world that is expected to see continued population growth for the next several generations. So the challenge of slowing climate change and improving child health in LMICs is that the imminent risks from climate change, especially warming, may be secondary to basic risks such as food insecurity and unsafe water. Basic food security, improved water security is part and parcel of economic development. The path to economic development for LMICs is intricately tied to fossil fuel and coal for decades to come. There are, of course, ways that we can make a difference, but those industrial processes are unfortunately very directly tied to fossil fuel and carbon emissions. The challenge, again, of slowing climate change and improving child health in MICs is tied to the large and conspicuous gap between high-income and lower-income populations. It's a challenge to our own prioritization of environmental protection. For good reasons, we would like to think, and we think that reducing carbon emissions is a high priority. That is a high priority. However, the more that we encourage progress here, in Palo Alto, in the United States, the less legitimacy we have in expecting environmentally protective changes in LMICs. We are connected to those communities in Nigeria or Ethiopia and Pakistan, and the further we stretch the cord, the rope that ties us to these communities, the longer the runway for these communities to reach their own state of development. Moving the goalposts of progress for those far behind extends the runway of high carbon emissions in the pursuit of economic development and child health improvements. As long as we have things like this in the New York Times, that this is what is expected. This is the health status in the United States. The new status symbol, full body MRI. Here at Stanford, very high intensity precision health is something that is beyond the imagination of most low-income countries. If people have seen the kind of prescriptions for extending longevity and health that are now kind of in the popular literature, that makes a big difference. That is very different from what we can expect and the kind of goalposts that we might want to have for countries to achieve convergence, for low-income countries to achieve convergence. So with that, I'll end. I'll leave you with one of my favorite quotes from Gandhi, with whom I share not only a haircut but also a birthday, that when in doubt, apply the following test. Recall the face of the poorest and the weakest man whom you have seen, and ask yourself if the step you contemplate is going to help him or her. And with that, a challenge to Stanford to lead the revolution, not necessarily in charging forward, but in waiting up, letting people catch up, seeing how we can really help those farther behind. And that will help us and reduce the future needs for high carbon emissions in low-income countries. Thank you very much.
Great. Thank you so much, Ron. So I want to invite up great. Just want to invite up Ari, Tom, and Aran. And now for the next half an hour or so, a question and answer period. Here's your chance to ask questions after these stimulating and thought-provoking presentations. Please come up and use the mic. Just state your name and your affiliation. So, questions?
What a great panel. Alan Schroeder from the Department of Pediatrics. You guys tell a great story about the adverse effects of climate change on our children's health, but the flip side of that is that the healthcare we provide has adverse effects on climate change. And I think I've read estimates that something like 5 to 8% of greenhouse gases come from the healthcare industry. And for people that don't believe that, I encourage you to come round with me and the 12 yellow gowns that my team puts on before going in to see every room that go straight into the trash. So my question for you is, why aren't we doing more in healthcare to sort of walk this walk? And given that a lot of the healthcare that we provide is probably unnecessary and wasteful, can we not be leveraging this sort of adverse effect on climate change as a reason to think about avoiding unnecessary procedures?
Yes, that's right.
So, Alan, nice to see you. I think I am. I've spent a good amount of time on that problem. And I think at its core, while many of us want to do the right thing, we are incentivized to do the wrong thing. And this is a broader challenge to all of us, which is in the United States, many of us in the room ask ourselves, and
I don't know
guessing that this question will come, so I'll get ahead of it, which is, what can I do to address this problem? Should I eat less red meat? Should I, drive a Tesla? Whatever. We have this idea that our individual choice will reshape the system. And just as with, I would say the power of individual choice around your diet, your transportation, is more about the cultural change we need to see than about the emission reductions it achieves. In healthcare, we get paid to do more. We get paid to deliver better outcomes, and whether you're talking about cardiac catheterizations or agricultural yields, if your policies incentivize the greatest gains in the shortest possible duration and externalize costs, whether that's in the form of gowns in the trash or food waste, we can't make individual choice work. So for healthcare to do this, we actually need payments that reflect the incentive. Now, I don't see payers lining up to do this. And I in fairness, I'm on the National Academy's Action Collaborative. I'm on the steering committee for the National Academy's Action Collaborative on decarbonizing healthcare with major leaders in the payer sector. And they want to do this, and they are having a hard time figuring out how to do this. So it's not that, it's just a flip of a switch. So my answer is, and in the decarbonizing healthcare space, Stanford Hospital is tied into a cogen plant, burning natural gas. My hospital is tied into a cogen plant. Our city is supposed to be net zero in 2045. How can we expect healthcare to do the right thing? And this is sort of a microcosm of what Aaron's saying. Like, if it's going to put us out of business, like, if we gave every low-wealth country in the world solar panels and wind power, and their carbon emissions went to zero, I would say, to Aaron's point, that the health outcomes are probably not going to be great. And so this is why we need good carbon policy. This is why we actually need policymakers to recognize the externalized costs, the fact that society is feeling the burden from climate change in our health, in our economic development, in our learning, children's learning, and effectively giving us the path forward so that it doesn't put us out of business to do that. So that said, there have been tremendous strides, right? Hospitals have done this. There are organizations that have led on this, like Healthcare Without Harm, that have really worked to figure out the best ways to reduce waste, to save energy. Kaiser Permanente has a goal of getting to net zero emissions. They are in a somewhat fortunate position of having lots of access to renewable energy, somewhat easier to do. The National Health System in England is committed to going to net zero. By the way, just for the record, the largest part of our emissions in healthcare is not in our buildings, it's not in our vehicles, it's in our supply chains, primarily our meds. And so the pharmaceutical companies that I've been speaking to, a lot of them are dead set on trying to get emissions out of meds. Now, how you do that, I don't know, because like fertilizer, everything we put into an IV bag and a pill is made more or less with fossil fuels. But nonetheless, this is like the sustainability stool question is, how do you engineer a new way to make a med or a new way to make a coating on a med that doesn't rely on fossil fuels and will do exactly what we need that med to do? This is an innovation challenge. So we need technological innovation for sure. We need policies that will enable us to do the right thing, whether that's in the payer sphere. I mean, there's been active conversation about carbon intensity-based, value-based payments. I think there was anyway, so, or we need actual, national level policies that will help drive us in that direction.
Thank you. I'm very sympathetic, and I think I share many of Ari's sentiments. I'll add one more that maybe is less about the kind of the incentives that are perverse, and maybe more in some ways kind of sympathetic to human nature. We all want better for our patients, for our children, for our communities, but that is that pushes us in the direction of more. The way that you see people address that is finding new technologies, new therapeutics, new approaches to diagnostics, right? All of this is just kind of leading us in some ways in the direction of actually making it more difficult to address the climate issues. Now, I'll say, and this is again, if I were to think a little bit, step back and say, like, how do we deal with this? One thing that comes to mind is, it's almost like, again, like thinking about sort of human nature, the desire for the human nature, as far as I can tell in history, the very human desire for more has actually not been satisfied by providing more. So in some ways it takes a different way of thinking about what are the goals, what are the kind of in some ways what is it that we want from life? Is it that we really just want to extend life or improve health in some way or another, or are there additional goals that we really want to in some ways keep in balance? And I think those are very difficult issues.
Great. If there's other questions, we can take another question. Otherwise, I can give my uninformed perspective as a non-physician who has not spent much time in a hospital at all. But I think we have to find ways to incentivize this, right? We need both the innovation with a school like the sustainability school, as well as some kind of incentive to insurance companies or others, where we can say, look, this may cost a little bit more upfront, but we're going to actually see reduced healthcare costs in the future because of reduced fossil fuel emissions in the environment. And so if we can put this investment in now to find perhaps innovative but perhaps more expensive ways to coat medicines, or come up with a reusable gown or gloves in an operating room, that in the long run this is going to reduce insurance costs overall, because we're going to see less people showing up at hospitals.
Well, a lot of people are thinking about questions. I thought I would throw it out here. This tension between economic development and that Ron talked about, just from a health perspective, what are the measurements besides infant mortality that we can look at that might be more sensitive measures that can give us some, because I think data, precision data would be very helpful in terms of very sensitive markers. As physicians, what are the markers we should be looking at that are most sensitive in terms of economic development, air quality, that we mentioned some in your talks, but what do you think would be a panel for environmental influence?
Well, how about you go here, and I'll formulate something.
I think that's a great question, and I think that I've been interested in doing research on birth outcomes. I think birth outcomes can serve as a bit of kind of the canary in the coal mine, right? Because we have births that are occurring relatively frequently compared to some other health outcomes. They are occurring across sociodemographic strata, income, race, ethnicity, geographic location, right? And so I think that looking at things like preterm birth, which in the United States is still 8, 9, 10% in most places, can serve kind of as a sensitive indicator for some of these things. But I want to pass it on to Ron.
Well, I'm not going to have a clear answer. I would almost think about the type of data, the type of measures that would be useful, and these would be things that are measured uniformly in large populations in ways that can be comparable over time. And so, it's not easy. Oftentimes we'll come up with a new biomarker but we have no idea what it used to be. Sometimes we also have certain diagnoses that change, kind of their definitions change over time. These make it difficult to really understand what is going on. So I would say that, sometimes for, at least certainly in the development context, mortality is it has been and it remains more or less a pretty well measured outcome. But I think things like preterm deliveries, certainly things that are related to pregnancy, to adverse pregnancy outcomes. These are all very useful. I would say again from the LMIC perspective, very intensive data collection, the kind of stuff that we might have here in EHR is something that is a dream, but it's not something that to be expected. But I think if there are things that can be very broadly measured, either through kind of remote sensing or very large population data collection, these are things that would be really useful for understanding what is going on.
Sure. All right, so I'm going to make the case that we don't need to do that. The data the most compelling data you'll see is what Aaron showed you, and air pollution is killing lots of kids. So let's just track that, right? That's the progress. We can see that signal very clearly. The data are there. Now, the second point is the data are unclear on heat because we haven't studied it. So there are almost no valid studies in low and middle income countries on heat. To my knowledge. I mean, they're extraordinarily few. Almost all of them have done global health. Now, that's important for a couple of reasons. One is it's an equity issue. The second is we need to remember that science is kind of like the drunkard looking for their keys, and they can only look under the lamppost. So in 2010, the world had like its hottest year. About a quarter of the Russian wheat crop went up in smoke, and Russia stopped exporting wheat. In the context of the worst heat wave, it killed something like 60,000 people in Europe, a lot of people in Russia. So what happened? Well, Russia decided we need to protect ourselves. We're going to stop exporting grain. Well, what happened? Russia at that time was the second or third largest exporter of wheat in the world. So children starved in low and middle income countries. Now, that's not going to show up in the studies, but it's clearly an effect of global warming on child health. So the other point, and the reason why the equity on research is important, is that there are a lot of studies. One of the studies that Aaron mentioned uses something called the wet bulb globe temperature. Who uses the wet bulb globe temperature? Well, no one in this room, but the US military does for its soldiers, because it is the most physiologically relevant measure of temperature. It integrates the temperature, the humidity, the wind speed, and solar radiation together in one measure. And the military learned in the Gulf War that if you want to predict whether soldiers are going to pass out, it's the most helpful predictor. It's been used going back. It's a really interesting history of the military use of this. Anyway, so turns out that there are studies going back maybe 15, 20 plus years now, where scientists estimated, okay, most of the Earth's population does not live at wet bulb globe temperatures that happen at any amount of time that exceed our body's ability to dissipate heat. So when you get hot enough and you get enough humidity, we simply just overheat. Most of humanity, civilization, remember folks, human civilization, 14,000 years, cities started rising. Before that, it was an ice age. Modern humans, about 50,000 years ago, we have gone where we have gone in the world in an era in which the temperature is much cooler. If we exceed the wet bulb globe threshold, which it's a whole other interesting conversation about what is the wet bulb globe temperature threshold that is too hot, the nice curves, the linear curves, don't work anymore. We get discontinuities. By the way, we've already seen this with plants. So we have nonlinear responses. This is work of David Luben, actually published in the Proceedings of the National Academy 20 years ago, looking in the United States at this issue of the reality that crop yields actually go up steadily as temperature warms in the United States, because we're temperature. But you get to a certain point, and they don't just go down in proportion to the rise, they go through the floor. So forget about people, think about food systems. And let me tell you, if you want to do some farm speculation, real estate, like buy in Alberta, folks. I'm not joking. Companies know this. So I guess that's my second point. The last point is this issue that also Aaron raised around economic development and health. So the reality is, if you took all of the LMIC's carbon emissions and added them together, they would be a fraction of this country's, a fraction. So let's not worry about whether low and middle income countries need fossil fuels right now for development. Let's worry about getting the technologies in place that will deliver low-cost energy that will hopefully prevent pollution, so that will be available. I mean, a lot of the future potential of climate depends on whether the technologies are available to decarbonize everybody at a cost that's affordable, right? That's the goal. And we need to make sure that when those things happen, they don't get held in the hands of the few. So again, energy poverty is lethal. It is lethal. And the solution to climate change will never be through a pathway in this idea of a just transition of denying people access to low-cost energy. That doesn't work.
Hi, everybody. Yeah, thank you for this interesting conversation. I'm going to try to put my thoughts in like something that will make sense. But basically, I wanted to bring up the issue of facing contradictory challenges when we're dealing with like improving child health and climate change. So I very recently like read a book that is called Donut Economics, and I don't know if anyone here is familiar with it, but basically it's a very profound now, I think, kind of like correlation. If you think of a donut, if you are inside the dough donut, that's where everyone thrives, okay? So like the climate, ourselves, and there is like wealth distribution. If you are like inside here, you're like living in poverty, and anyone who is living outside of the donut is like basically pushing our environment, like, you know, to in this state that I guess like we're all worrying that it is. And my comment is that we live in a country, right, that it is all about continuous economic growth and growth and growth. And that obviously comes in juxtaposition to like having a healthy planet. And earlier you showed the graph where there is like all these countries where kids live in poverty in terms of the consumption of calories and the annual income, and then the United States like on the other side, right, where it's like overconsumption. And we see that, you know, earlier the point was about healthcare, but I think overconsumption is just like in every single field. And so that's like one contradiction that I see in terms of like overconsumption in all different fields. And the other one, thinking about innovation, you mentioned about the, what was it, ammonium nitrate that helped improve like the crop yield, but then that is associated with a higher CO2 emission. So on one side, you have more crops to help with the malnutrition, but then climate change. So generally, sorry, like I spoke too much, but basically what I wanted to say is that there is this like struggle with, on one hand, improving something that might be helping with, economic growth or malnutrition, but then on the other side, we're kind of like going against climate change, helping our climate. Yeah, sorry, loaded, but these are my thoughts. Thank you.
I agree.
Perfect.
My question's really almost derivative. It's quite simple. I don't know, am I the last question, Tony? I don't know.
Yeah, depends how long the answer is.
Okay, so, you know, in MCHRI, we're trying to train the next generation, so we're getting people to get degrees in epidemiology, and your talk was just spectacular. And then we're putting in infrastructure in place, so things like PEDSNet and data to enable the research. And then we have $50,000 seed grants, and we also have $200,000 grants if you work with another school, i.e. the School of Sustainability. So as we start to think about the kinds of grants we want to fund and the things we want to be doing, ultimately all of this is to trying to leverage extramural funding. So my question to all of you is, where is the funding, extramural funding? Like, is NICHD putting out calls for applications in climate? Pardon my ignorance. I mean, the first thing I want to do is go back to my computer and get into NIH Reporter and see what they're doing. But, you know, is NICHD doing calls for applications and having RFAs or convenings at Thatcher Auditorium, or the things that are going to start creating these opportunities? What foundations are funding this work? What are the extramural sources of funding to advance this work?
Yeah, I mean, I can talk a little bit about EPA,
Yeah.
you know, and I assume many federal agencies that give out grant funding, and I don't know all of the ones that do, but I mean, with the Inflation Reduction Act and then some of the other recent, I mean, we have so much money that we are going to be trying to give away in the next 4 years. And I think that, I guess one of my recommendations is, even if you see an RFA that doesn't say climate change exactly, if you see other kind of buzzwords like cumulative impacts or environmental justice, I think all of those, you can make a very easy, nice story about how climate change is part of a cumulative impact when we're talking about kind of the exposome or multiple joint effects, or environmental justice or social determinants of health. You know, thinking about the way that people experience heat in different communities, and what, you know, how they experience heat if you live in a poorer community or a more affluent community. And so that would be my recommendation, is to look for cumulative impacts, which is a big buzzword at EPA at least, environmental justice, if not climate change itself. But I don't know specific sources.
That's tremendously helpful. And so, you know, Stanford pays to be part of something called Pivot, which is this database to search for funding. So I think one of the things we can do, Tony, is try to get out and catalog all the places that would be receptive to this. Those buzzwords, those search words are really tremendously helpful, so we can help guide some of our folks to getting their foot in the door into those places that maybe we don't traditionally go or look.
So I have to ask you two questions. One is, do you have a shovel? And
A
shovel. And the second is,
shovel.
can you confirm or deny the rumors I used to hear, which, given the exorbitant salaries paid to Stanford faculty, they used to stash money under the floor of Fairchild?
No shovels, and I'm not aware of that funding stream.
Because, you know, this is where Fairchild Auditorium was, so I
Yeah.
just figured we could just start digging and find your funds. So look, the NIH has done a tremendous job of trying to focus attention on climate. So there's an NIH-wide initiative focused on climate change. There is a, what do they call it, a special priority. I can't remember even the lingo. But the bottom line is that applications going to NIH now across NIH, that are focused on climate change get a leg up in a competitive score.
Okay.
So that's one thing. The second thing is NIH is putting a substantial chunk of change behind climate-based research. In the external stakeholder engagement that Rick Wychick held for NIEHS, the number one priority for NIHS among external stakeholders by a vote of fourfold was climate change. Okay? More than precision medicine, more than all the other things that environmental health does. Climate change by election. So there is a mandate, there is a framework. I don't know that they have put out specific, and I'm going to be talking to Gwen Coleman soon. They may have even now put out specific RFPs focused on this issue, but there is a well-established and growing interest in NIH. There were, actually, I do know they had wanted to establish centers of excellence on climate and health. The funding didn't come through with that, so they have established, I think, research coordination centers. There's one at Harvard and BU, led by Greg Wallenius and Francesca Dominici. But I expect these funding opportunities, and that's really, again, focused on community engagement and training. So I think that NIH is revving up quickly, and I expect it to continue to grow in that arena. And that's not just NICHD, it's really very widespread across the agency.
Well, I just have to congratulate you, Tony, and your committee, because this was an extraordinary combination of speakers, and we should all, I know I speak for everyone, that we're really motivated to start thinking about how to be responsive to those opportunities, so thank you.
So to thank the speakers. Yeah.